Naveen, we have come to the most toughest part of hematology experiments.
Yes,
I
ma'am.
hope you understand how difficult it was during your practical sessions.
Definitely, ma'am. Yes, ma'am.
Okay, fine. So we'll be seeing about differential leukocyte count.
Yes, ma'am.
Shall I ask questions to you?
Yes, ma'am.
Okay, fine. This is called peripheral blood smear, right?
Yes, ma'am.
Using that only, you're going to do the differential leukocyte count. What are the uses of peripheral blood smear?
So it's used to study the morphology of the cells, that is RBC, WBCs, and platelets,
Okay,
and to detect any parasites that are present in, like trophocytes forms in the malaria,
okay,
filarial parasites,
good.
and it serves as a permanent record, ma'am.
Mm.
And also, we could determine the sex based on the bar body that are present on the nucleus of the neutrophils, ma'am.
Okay. So this is a permanent record so that it can be used as a prognostic factor for the disease
Yes, ma'am.
or to assess any the response to the treatment
Yes,
also.
ma'am.
Okay, so that way it is a very useful tool in diagnosis.
Yes.
Okay, fine. Now, what is the difference between an absolute count for any cell and a differential count?
Absolute count is calculated with the values of DLC as well as the TLC, ma'am.
Okay.
Whereas differentiate leukocyte count is the only taken the percentage of the only the type of the leukocytes, ma'am.
Okay, so absolute count can be calculated if you know the DLC
Yes,
percentage
yes,
and the
ma'am.
TLC. We can just calculate the percentage and this much of TLC. For example, if it is 6,000, 40% of 6,000, how much it is? That will be the
3000.
absolute count.
Yes, ma'am.
Right. Okay, fine. And nowadays, absolute count is not done manually. We use Coulter monitor for
Yes.
that. That is also there. Fine. What are the features of an ideal blood smear?
So the ideal blood smear should cover at least one half to the three-fourth of the slide, ma'am,
Okay.
and it should be feathery.
Ideally, it should cross the midline, we used
Uh,
to say.
yes, ma'am.
Mm.
Okay, initially it should be thickest and gradually it should thin out, ma'am. There shouldn't be any gap or mm, any dust particle
Streaks also should
streaks.
not be
Yes,
there.
ma'am. And
Okay.
it should be one cell thick, ma'am.
One cell thick. Okay. What is the shape of the smear?
Tongue shape,
Tongue shaped. Tongue shaped with feather edges
feather
is the
edges.
ideal one.
Yes, ma'am.
Right. Okay. How do you confirm whether it is one cell thick?
We'll check whether any cells gets overlapping or not.
Okay. So there should not be any overlap.
Overlapping.
Most of the cells are the RBCs. Okay, because they are in millions. They just touch each other or just overlap, just uh, near to each other. Okay, so that is the indication of one cell thick layer,
Yes, ma'am.
right? Okay, what is a stain that you will use for doing differential leukocyte count?
Leishman stain,
Okay, tell me the composition and function.
methylene blue, using acetone free methyl alcohol, ma'am.
Okay,
So methylene blue stains the acidic part, that is the nucleus.
okay,
Eosin stains the basic part, that is the eosinophilic granules and hemoglobin.
okay,
And acetone-free methyl alcohol, it's used to fix the cells to the smear, ma'am.
okay. Fix the cells to the slide
Slide,
actually,
yes, ma'am.
right? Okay, why it should be acetone free?
So acetones are highly lipid solvent, ma'am. So it ruptures the cell membrane, thereby the cells are shrunken, ma'am.
Okay, so the cells will become distorted or crenated
Yes, ma'am.
if you use acetone. Okay, fine. Now comes the star question. Any other stain that you can use for doing this DLC?
Right stain,
Okay, good,
field stain,
good, very good.
Gimsa stain.
Yes, excellent. So you are a star student. Okay, fine. So now comes the procedure.
Yes, ma'am.
What is fixation time and what is staining time?
So fixation time is 2 minutes. So basically, it is the waiting time after adding the stain to the dried smear, ma'am.
Okay,
During this time, the smear gets attached to the slide with the
okay,
help of methyl alcohol, ma'am.
okay. So let me explain further.
Yes, ma'am.
This methyl alcohol goes and precipitates all the plasma proteins in the
Oh.
blood. Okay, so this precipitated plasma proteins will form a glue-like thing which goes and gets fixed over the smear.
Okay.
So while this glue is fixing, it also drags the cells and completely fixes the smear.
Okay.
Okay, now and this fixation will happen only if the smear is completely dried. After
Okay.
making the smear, it should be completely dried.
Yes, ma'am.
After that only, if you add the stain, the alcohol will fix the
Okay.
cells.
Yes, ma'am.
Right. What is staining time?
Staining time is 2 to 8 minutes, ma'am.
Mm.
So it is the waiting time after adding the distilled water to the right smear, ma'am.
Okay. Why after adding distilled water is the staining happens?
So after adding the distilled water, the dye gets ionized. Thereby, it penetrates into the cell and gives the color, ma'am.
Very good. Okay. Can you add any other agent instead of distilled water?
Mm. Buffer solution.
Yes. Actually, buffer solution is the ideal one.
Okay.
Okay. But distilled water is easily available and cost effective, so we use distilled
Yes,
water. Fine. Okay. Now the smear is done. Staining is done.
Yes,
It is ready to be uh,
seen in the.
counted.
Yes, ma'am.
Okay. Number of cells we can identify now under the microscope. Okay. Can you tell me what are the microscopic adjustments for oil immersion?
So the mirror used is plain mirror, ma'am.
Okay.
And
How will be the condenser?
condenser is fully raised and the
Okay.
diaphragm is fully opened, ma'am.
Fully open. Very good. Okay. Which objective lens you will use?
100x.
100x oil immersion. Okay. You use cedarwood oil, right?
Yes, ma'am.
Why should you use that?
Cedarwood oil has the same refractory index that of the glass, that is 1.5, around 1.5.
Mm.
So which prevents the air glass interference, thereby it's produce maximum illumination is established, ma'am.
So it prevents the refraction
Yes, ma'am.
by preventing the air
Air
glass
glass
interface.
interference. Yes, ma'am.
Okay, so this is again a very important question and frequently asked question by the examiner. They asked why you use cedarwood oil. Most of the students will say this is oil immersion, that's why I'm using cedarwood oil. It's not for that reason. It is the reason for this refractive index thing.
Yes,
Okay, so it has got the same refractive index like that of
ma'am. Glass.
glass.
Yes, ma'am.
And can you use coconut oil or
No, ma'am.
groundnut oil? No,
No, ma'am.
it is only the cedarwood oil. Okay, fine. So you have added oil and you are just scanning through the peripheral smear, stained smear, and you should go in a zigzag manner. Okay, so that it covers the entire most of the length of the smear.
Yes, ma'am.
Right. Okay. Now, which portion is ideal for counting the cells? I mean identification and counting both.
So it's a junction of the body and the tail, ma'am.
And you should move towards
The head part.
no, you should move towards the tail part.
Okay.
You should start from the junction of the body and the tail and you should move towards the tail part.
Yes, ma'am.
Okay. In this actually they used to say the heavier cells like monocytes.
Okay.
And the even eosinophils which has got coarse granules. All these cells will be pushed towards the tail end. So you
Okay.
can find more number of monocytes and eosinophils there in the tail end.
Okay.
Okay.
Yes, ma'am.
So tail end only you have to see, and you have to go in a zigzag manner so that it covers the entire breadth of the smear.
Yes, ma'am.
Okay, so that's how you can assure the uniformity of cell
Yes,
identification.
ma'am.
Okay, now coming to the cell identification, how will you differentiate between a neutrophil and an eosinophil?
Neutrophil is double the size of the RBCs. It is multi-lobed, that is 2 to 6 lobes of the nucleus, and it has the fine granules, ma'am, which is in pink color.
Yes,
Yes.
fine pink granules.
Also, eosinophil is twice the size of the RBCs. It has the peculiar headphone shaped or spectacle shaped nucleus, ma'am, that is two lobed, and it has the coarse granule which is brick red in color, ma'am.
Very perfect. Okay, how will you differentiate a lymphocyte and a monocyte?
Lymphocyte is the twice the size of the RBC. Its nucleus almost covers the cytoplasm, ma'am, that is 80%, and only we could see the rim of the cytoplasm which is in blue color, and there won't be any granule, ma'am. And monocyte, it is thrice the size of the RBCs, and the nucleus here is in horseshoe shaped or kidney bean shaped, ma'am. And cytoplasm is clear, and there won't be any granules in it, ma'am.
Yes, but sometimes they used to say even the cytoplasm of monocyte has got some azurophilic granules.
Okay. Okay,
Okay,
ma'am.
and sometimes the cytoplasm will be in the appearance of ground glass.
Okay.
You know what is a ground glass
Yes, ma'am.
appearance? What is it?
And it is also seen in the viral hepatitis. The glycogen will be stored.
Okay, it just looks like if you apply a powder over the glass and
Okay.
see how hazy it is. So that much hazy will be the cytoplasm.
Okay, ma'am.
That is called a ground glass appearance. Okay, fine. How will you differentiate a small lymphocyte and a large lymphocyte? There are two lymphocytes,
Yes,
right?
ma'am. Small lymphocyte is the same as the size of RBCs. The nucleus will be completely covering the cell, ma'am, and there won't be any cytoplasm or very scanty cytoplasm.
Okay.
Whereas in the lymphocyte, it is twice the size of the RBC,
Large lymphocyte.
and also nucleus covers the 80% of the cytoplasm, and bluish cytoplasm is seen, ma'am.
Yes, good. So ideally, the small and the large lymphocyte, how will you differentiate? The very first answer to be told by the student is based on the size.
Yes, ma'am.
Okay, so it's small and large is based on the size, right? So that should be the answer.
Yes, ma'am.
Right. Sometimes even the examiner will ask, what are the different types of lymphocytes that you will see in the blood smear? Many students will answer T lymphocyte and B lymphocyte.
Yes, ma'am.
Okay, you cannot differentiate T lymphocyte and B lymphocyte morphologically. Morphologically, what you can say is small and large lymphocyte.
Yes, ma'am.
T and B lymphocytes are differentiated based on the surface markers,
IHC marker.
CD
Yes, ma'am.
markers. Okay, so not based on the morphology.
Yes,
that you should clearly understand. You
Yes.
should not tell that B and T, that though that is a functional classification.
Yes.
This is a morphological classification.
Yes, ma'am.
Okay, fine. So let me sum up all the identification aspects of all the cells.
Yes, ma'am.
You know there are 3 granulocytes and 2 agranulocytes
Agranulocytes, yes, ma'am.
normally. Okay, all these cells are identified based on 3 factors. One is the size, the other one is the nucleus, the third one is the cytoplasm.
Yes, ma'am.
Okay, for neutrophil, the size is twice the RBC. Okay, nucleus 3 to 5 lobes, and cytoplasm, it has got fine pink granules. The normal count of neutrophil is 50 to 70%.
Yes, ma'am.
For eosinophil, it is also the same size, twice the RBCs. The nucleus is 2 lobed. The typical shape of the nucleus is spectacle shaped or headphone shaped.
Yes, ma'am.
Okay, and the granules here is coarse, brick red in color.
Okay, ma'am.
The percentage of eosinophil is
20 to 40.
eosinophil Naveen 1 to 4 percentage. Okay, and basophils, this is also twice the size of RBC. The nucleus is there, but it is almost obscured by the thick gray, dark gray colored coarse granules. Granules will be scattered throughout the cell.
Yes, ma'am.
Okay, so you will not be able to appreciate the nucleus at all. The percentage of basophil is very meager, actually 0 to 1 percentage. You
Yes,
know
ma'am.
why? Because the basophils, when it is released into the circulation from the bone marrow, immediately it will enter into the tissues.
Okay.
And it forms macrophage system, and it belongs to that.
Okay,
Okay,
ma'am.
so it is found very less in the circulation.
Yes, ma'am.
That's why it's less. Okay, lymphocyte, the size is almost twice the RBC if it is large, and same size if it is small,
Yes, ma'am.
like that of an RBC. And nucleus is, for a large lymphocyte, 80% of the nucleus, 20% of the cytoplasm. No granules.
Yes, ma'am.
Okay, the percentage of lymphocyte is 20 to 40
yes, ma'am.
percentage. Okay, small lymphocyte also, it is the same size of RBC, nucleus covering the entire cell.
Yes, ma'am.
There will be just a purple dot. That's it. All that you are seeing is a nucleus. And for monocyte, it is the largest cell of all the 5 cells. Okay, it is thrice the size of RBC. Okay, nucleus occupying 60% of the cell, kidney shaped or bean shaped or horseshoe shaped.
Yes, ma'am.
Cytoplasm, bluish in nature. Sometimes azurophilic granules may be present, sometimes it may be
Ground glass
ground glass
appearance.
appearance is seen.
Yes, ma'am.
Okay, the percentage of monocyte is 1 to 5
Okay, ma'am.
percentage.
Yes, ma'am.
Okay,
Yes, ma'am.
now after this they will ask questions on conditions that produce increase and decrease
Yes, ma'am.
in the cell counts, different types of cells. I'll ask you one star question.
Yes, ma'am.
What is Arnett count? Cook Arnett count. Have you heard of it?
Arnett count. Yes, ma'am. It's used for the WBC, the shift.
You are partly right.
Forgot, ma'am.
Okay, I will explain. See, Arnett count, it's ideally called as Cook Arnett count. Okay, this is actually like in WBC, in DLC, what you are doing is you are counting all the different types of WBCs for 100 cells. First 100 cells you will count and you will take the percentage of each type, right? Here what you do is you will count only the neutrophil.
Okay.
You will count all the 100 neutrophils and you will just calculate the neutrophils based on the number of lobes. If it is one lobe and you count it as one lobe, very rarely found, 1 or 2 lobes, you mark it as N1, 2 lobes N2, 3 lobes N3, 4 lobes N5, 5 and above 4 lobes N4, 5 and above you mark it as N5, like
yes,
that, N1, N2 and N3, like that. Then you will plot a graph, how much is N1, how much is percentage is N2, how much percentage is N3 and how much is N4 and N5, like that. Okay, N3 is said to be the normal percentage. Okay, one more thing is, if the lobes are very lesser, less than 3, they are younger cells.
Okay.
As the number of lobes increases, it is indicating that the cells are very mature or hyper mature and they are older cells, senescent cells.
Yes, ma'am.
Okay, so the more the number, the more the age of the neutrophils. Normally N3 cells will be found in a majority. Okay, N1 and N2 means the percentage of N1 and N2 are found more, means that means your bone marrow is active and produces more cells.
Yes.
Hyperactive in a way. Okay, if N3 and N4 cells are present more, means in your bone marrow is suppressed. Okay, so if you draw a graph, in the middle you have got N3. N1 and N2 this side means it is to the left of the graph. So leftward shift means then the bone marrow is active. Hyperactive. Rightward shifts, that means if N4 and N5 cells are more, rightward shift means then the bone marrow is hypoactive.
Yes, ma'am.
That is the indication. That is the utility of this Cook-Arnett count. Okay,
yes,
are you clear?
Yes.
Yes, good. Naveen, this is for all. Okay, this is the summary of all the cell types and the abnormal associated diseased conditions. Okay, most of the examiners in the viva, they will ask about the normal cell count and increased condition, decreased condition. Okay, so you will be able to answer that condition, name of the condition specifically. For example, if the RBC is the experiment, they will ask what is increase in RBC count? What is it called?
Polycythemia.
What is decrease in RBC count called?
Anemia.
Yes. In WBC, what is increase in WBC count called?
Leukocytosis.
Decrease called?
Leukopenia.
Yes. Okay. And they will ask leukemia. What is leukemia?
Yes,
okay. So that is also increase in count with malignant nature. Okay. Platelets. What is increase in platelet count called?
Thrombocytosis.
What is decrease in platelet count called?
Thrombocytopenia.
Yes. Very simple it is. Okay. So they will ask conditions for increase and decrease condition. Okay. Similarly, neutrophil, individual different leucocyte count, when you get that experiment, they will ask about individual cells. What is increase in neutrophil count called?
Neutrophilia.
Neutrophilia.
Yes,
okay. The causes for neutrophilia is acute bacterial infection, pyogenic infections, exercise, okay, inflammatory disease, all these.
Yes,
okay. What is decrease in neutrophil count called?
Neutropenia, ma'am.
Neutropenia. Okay. The causes may be maybe typhoid fever should be your first cause. Okay, enteric fever, typhoid and paratyphoid fever is the first cause. Aplastic anemia, and physiologically chronic exposure to cold condition. Okay, What is increase in eosinophil called?
Eosinophilia.
Eosinophilia. Okay, this is again the common usual question by
Yes,
the
ma'am.
examiners. Okay, the causes for eosinophilia includes allergic infections like asthma, hay fever,
Yes, ma'am.
parasitic infestations like roundworm, hookworm, hydatid disease, okay, filariasis, or in some skin diseases like psoriasis,
Psoriasis.
pemphigus.
Yes,
All
ma'am.
these are conditions which produce increase in eosinophils. What is decrease in eosinophil count called?
Eosinopenia.
Eosinopenia.
Yes.
Cushing's disease,
Yes.
steroid therapy, ACTH therapy. Okay, all these can cause decrease in eosinophils. Why steroids is involved in this? Any reason, any justification for this?
I have no idea, ma'am.
Steroids actually what it does is it takes all this basophil, eosinophil lymphocytes, all these type of cells, it takes it to the spleen and helps in the sequestration, early
Okay.
sequestration of these cells in the spleen.
Okay.
That's why when you are taking steroids, these cell count will be less.
Okay.
Okay, so that is one of the important cause for eosinopenia. Basophil, what is increase in basophil count called?
Basophilia.
Basophilia. CML, chronic
CML,
myeloid leukemia,
leukemia.
will end up in basophilia
Yes,
also.
ma'am.
What is decrease in basophil count called?
Basopenia.
Basopenia. Okay, again aplastic
Aplastic
anemia,
anemia.
you will have decrease in basophil count
Yes,
also. The next is lymphocyte. What is increase in lymphocyte called?
Lymphocytosis.
Lymphocytosis. Okay, any chronic infections, viral infections, cancer, all these will produce increase in lymphocyte
Yes,
count. Okay, what is decrease in lymphocyte count called?
Lymphocytopenia.
Lymphocytopenia.
Yes,
Okay, so again lymphocyte, ACTH therapy, immunosuppressant therapy, HIV,
Yes,
all
ma'am.
these will cause decrease in
Yes.
lymphocyte count. Monocyte, increase in monocyte is called
Monocytosis.
monocytosis. For example, protozoan
Yes, ma'am.
infections like malaria, Kala Azar, all these conditions will produce increase in monocytes.
Yes, ma'am.
Okay, and decrease in monocyte count is called
Monocytopenia.
monocytopenia. Aplastic anemia or bone marrow depression can
Yes,
produce
ma'am.
monocytopenia. Okay,
Yes,
can we
ma'am.
have a rapid fire round for this?
Yes, ma'am.
Ready?
Yeah.
Okay. Increase in RBC count,
Polycythemia.
decrease in RBC count,
Anemia.
anemia. Okay, fine. Increase in WBC count,
Leucocytosis.
decrease in WBC count.
Leucocytopenia.
What is leukemia?
It's a malignant condition in which WBC is raised.
Okay. Increase in neutrophil count,
Neutrophilia.
decrease in neutrophil count.
Neutropenia.
Increase in eosinophil,
Eosinophilia.
decrease in eosinophil.
Eosinopenia.
Okay. Increase in lymphocyte count,
Lymphocytosis.
decrease in lymphocytes.
Lymphocytopenia.
Increase in basophil,
Basophilia.
decrease in basophil.
Basopenia.
Increase in monocyte,
Monocytosis.
decrease in monocyte.
Monocytopenia.
Okay, just remember two conditions for increase, two conditions for decrease. You
Yes,
need not remember the entire list of conditions that is given in the textbook.
Yes,
Just two conditions for increase, two conditions for decrease.
Yes, ma'am.
Okay, again one star question. With this we'll finish DLC.
Okay, ma'am.
Naveen. Okay, what is leukemoid reaction, Naveen?
Leukemoid reaction. As the name is self-explanatory, it is like the leukemia.
Okay.
So it is the transient condition in which increase in lymphocytes, ma'am.
Increase in lymphocytes to a tremendous value.
Yes, ma'am.
Okay, normally leukocytosis will happen maybe 30,000, maximum 20-30,000. Okay,
ma'am.
not more than that. In leukemia only you will get count more than 50,000. But in leukemia reaction also the count will be 50,000 to 1 lakh somewhere. But all the cells will be functionally effective,
yes, ma'am.
viable. Okay.
During stress we can.
Yeah,
Okay.
during stress or during severe hemorrhage.
Yes, ma'am.
Okay. ACTH therapy,
Yes, ma'am.
sometimes you get this leukemoid reaction.
Okay, ma'am.
Okay, fine, Naveen.
Ma'am,
You are
also I have a doubt.
yes, Naveen.
So how to point the cell after focusing to the microscope?
Okay, this is a very good question. Suppose the examiner comes and asks you focus a neutrophil and show it to me.
Yes,
Okay, in some of the colleges even the question itself will be like this, focus a lymphocyte, like that. So in that what you have to do is which time is your favorite time? 3 o'clock, 6 o'clock, 9
6
o'clock?
o'clock.
6 o'clock. Okay, you always bring the neutrophil or a lymphocyte in the 6 o'clock
Hmm.
position. Like in the clock you have got different arms,
Okay,
right?
yes,
3,
ma'am.
6, 9, 12, 11, like that. Okay, so in that 6 o'clock position you bring that cell and focus and show it to them.
Okay.
Sometimes what the examiner do is they will focus and cell and they will ask you to identify
At
what
what
is the cell
position?
that is present in the
Okay.
11 o'clock position.
Okay, ma'am.
Like that they will ask. You'll have to remember the clock and its
Hmm.
arms, and you have to
Move
focus on
accordingly.
that particular cell.
Yes, ma'am.
Okay,
Yes.
any more doubts, Naveen?
No, ma'am.
Okay, so now you have become very what to say, proficient in DLC. I
Yes, ma'am.
hope so. You will answer better.
Sure, ma'am.
Good.